On behalf of the National Eczema Association, I'd like to welcome you all to our webinar presentation, Unpacking Comorbidities in Children with Atopic Dermatitis. I'm your host, Danny Morsehead. Today's webinar is made possible in part by an educational grant from Sanofi Regeneron. Our presenter today is Dr. Amy Paller. Dr. Paller is board certified in pediatrics, dermatology, and pediatric dermatology. She's also the chair of the Department of Dermatology and director of the Skin Biology and Diseases Resource-Based Center at Northwestern University's Feinberg School of Medicine. And with that, I'm pleased to introduce you to our presenter, Dr. Amy Paller.
Thanks so much, Danny. I will go ahead and share my slides here. I think we're over here. Can everybody see that? Looking okay?
Looks
great. Good. All right. Well, today we're talking about comorbidities. And some of you may not even know what that word means, so we'll make sure to define that. But I'll go ahead and share with you a little bit more about eczema itself. I'm a pediatric specialist, so eczema is near and dear to my heart because I don't think I have a day in clinic in which I don't see many children who have eczema, or as we scientifically will say, atopic dermatitis, or AD. So AD is the most common inflammatory condition of skin in pediatric patients, particularly in industrialized countries. There is an association between industry and urban and an increased risk. Overall, the prevalence is in the range of 5 to about 20% of children. And you can see particularly common globally. The age of onset is what really makes it largely pediatric. AD develops by 5 years of age in 85 to 90% of patients. Most develop it by 2 years of age. And it's not uncommon to see cases in children that are moderate to severe. And depending on the study you read, that's 10% to 50% that are in that moderate to severe range, which means that they may need more aggressive therapy. Now, this is a complicated graph that was published a few years back, but I think it just tells you what we've learned more recently, that there are many different subgroups of atopic dermatitis, and they all have very different courses. As you can see on the left here, we're talking about babies who have that very early onset, and a large proportion of them can remit, usually between about 3 and 6 years of age. There are others that persist despite that early onset, and then others that come up at different times of life: childhood, adolescence, adult onset, and even very late onset, at greater than 60 years of age. Now, it's been shown that about 7% of adults in the US are affected. So a lot higher than what we used to think, but still less than what we see with onset during childhood. Now, when we make the diagnosis, it's really clinically. There's not a particular lab test that needs to be run, and certainly not a biopsy that we would need to do unless it was a difficult diagnosis and we were thinking and looking for something else. One of the criteria for making this diagnosis is the specific appearance of the skin, and every picture I'm showing you here is within the realm of what we call eczematous skin changes. But it is also the distribution that helps us to make this diagnosis, in addition, of course, to the dry skin and the itch that goes along in the vast majority of patients. Now, the distribution in babies tends to be different from what we might see in adolescents and adults. And although it's not 100%, very commonly we see a lot on the face of babies, particularly on the cheeks and on the chin. The diaper area is typically spared, which I've always found intriguing and suggests either it's the increased humidity of the diaper area, it's prevented from contacting things in the environment, or maybe it's just because it prevents the child from getting in there and scratching very much. So all of these are possibilities. Now we see, in addition to the face, we can see the trunk often affected and what we call the extensor surfaces. Not the fold surfaces, but the back sides of arms and legs being more affected in these very young ages. I also want to point your eyes out to the upper right-hand picture. You see it's shiny, it's swollen, it's actually oozing liquid. And in fact, this is so commonly seen, particularly on the cheeks of babies, because it's so inflamed and so swollen, but is often misdiagnosed as infection. Now, once we get a little bit older into children, there's less of that oozing. There's more in the typical fold areas that we think about. And by adolescents and adults, we've got more skin thickening because there's been chronic atopic dermatitis. Now it's almost always localized to fold areas and areas like the wrists and the ankles, hands and feet on either side, the head, especially now, not the cheeks and chin, but rather the eyelids, around the mouth, around the eyes, and then also quite a bit on the neck. So distribution is something that's quite critical. Regardless, itch is a critical component of atopic dermatitis. And as we all know here, the itch is what is life-altering. Now I'm going to spend some time talking about the impact on the child. So this is the proportion of children who suffer every day. This is based on the patient-oriented eczema measure, or POEM questionnaire. And that's shown here on the right from this particular study that we did just in the last few years. And if you look, there are 7 questions asked in the POEM questionnaire, starting with skin itching and disturbed sleep. And anybody who is shown here in red is every single day. So that's now translated into the numbers that you're seeing here in the left-hand picture, whether we're talking about 60% of all of these children with eczema having itching every day, 31.6% disturbed sleep, 62% dryness, 40.7% cracking. We see flaking, we see bleeding, we see weeping. And again, in more than 10%, every one of these is happening every single day. So this is tremendously life-altering for some children. But I also want to draw your attention to the POEM questionnaire results, because no days is in the blue. And you can see that there may be a certain percentage, actually a little more than 50%, that don't have weeping and oozing every single, that don't have weeping and oozing as part of the picture of their eczema. You can see that in any other criteria, we're talking about pretty small numbers that don't suffer at least 1 to 2 days, and as shown, often every single day. So what about this burden? Well, it's often that itch, but other factors that can translate into sleep disturbance. And as you can see here on the left, the increase in severity of the atopic dermatitis, with the red bar on the right of each section being your severe, we're seeing a lot more who have those 0 or 2, as you can see popping up here, nights of adequate sleep per week. That means the majority are not. And it's the lowest, of course, along those people who don't even have sleep issues. If we looked at frequent awakenings, there are certainly many children who have trouble falling asleep, but frequent night awakenings are even more of a problem. And you can see that as you get up into the severe, now shown in blue, there's more than what we see with those with mild disease. But notice, even with mild disease, we see these night awakenings. And here it's shown on the right with 162 nights out of the year with night awakenings in those with severe disease, and 33 nights, so that's more than a month of nights with night awakening in those with even moderate disease. Well, how about school attendance? This is a study that was done many years ago from Canada, and it showed that 20% of children miss school because of their atopic dermatitis. And if you pull that out even more, you can see that 12% overall miss more than 20 days of school. And think about that. That's a whole month of school within a given school year. And this is showing you broken down by age. So if we're looking at the bottom of 2 to 13 years versus the adolescence, that very critical time of being in school, and yet we can see that we're seeing a lot of school days each year, particularly in those adolescents. Performance can also be impacted. Shown on the left, patients with schoolwork or life affected by atopic dermatitis. Again, almost 50% of those who are teenagers. And during an exacerbation, that is also quite high. Now, this is a score called the Children Dermatology Life Quality Index, or the CDLQI. And there are different strata that tell us how much a disease affects quality of life. This is the most commonly used scale to try to measure this in children with skin disease. And this is just for a group of children who are very young, 4 to 6 years of age, in whom there was asked about the impact of quality of life of their atopic dermatitis during the past 12 months. And you can see that in those who are mild, even there was a small to moderate effect on their quality of life. For those who had moderate disease, it got into the very large effect range. For those with severe disease, extremely large effect on quality of life. And as you can see, based on these little stars that are over the columns, those who were moderate severity had a significantly increased impact on quality of life versus those who were mild, and those who were severe had a significantly impact quality of life versus those who were mild. So let's get into comorbidities. Now, first of all, do you even know what comorbidities are? I'm sure many of you do, but not all of you. So I just want to let you know that a morbidity is a sickness, and a comorbidity means that in addition to having the atopic dermatitis or eczema, these children will have some other problem in association that can be related to the atopic dermatitis, but is not part of the atopic dermatitis. And the first one I want to highlight is infections. And there are two major categories that are particularly increased. One is bacterial, and the other is viral skin infections. So there's a bacterium called Staphylococcus aureus, or Staph aureus, and this colonizes the majority of individuals with atopic dermatitis, with increase in being able to find that colonization, for example, by doing a culture in those who have more severe disease. Now, this increases the susceptibility to infection, and I'm showing you pictures of children who are infected, and you can see it looks pretty nasty. We often may have to give an oral antibiotic. Now, we never want to give an oral antibiotic to anybody with eczema unless there is an infection. But an interesting fact is that infection so can make eczema worse that often when we can give an antibiotic and clear infection, we see a marked improvement as well in the eczema itself. Now, I also want to make a note about doing cultures in those who have eczema. So if I cultured somebody with eczema, and particularly with moderate to severe disease, there's a really good chance, even if it looks perfectly fine, I see no evidence at all of infection, that I'm going to find that Staph aureus. So we don't do cultures if we're just looking to see if it's infected. We have to use our clinical judgment based on something being more inflamed, based on oozing, crusting, various signs of infection. The one time we might consider doing that is if we're thinking about what the organism may be, and particularly whether it's going to be sensitive to the antibiotic we may choose. Staph aureus can come in two major flavors. One is staph that is sensitive to methicillin, and the other is staph that is resistant. So one is called MRSA, methicillin-resistant Staph aureus. The other is called MSSA, methicillin-sensitive. And the problem is, if you don't think about the possibility that it could be Staph aureus that is resistant, you may end up treating with an antibiotic that's not going to do the job. And so that may be a reason to culture and look for that possibility. On the other hand, of course, we don't want to treat everybody with something that's good for methicillin-resistant Staph aureus, because the problem may be that they then, unfortunately, will be treated with an antibiotic when they don't really need to be treated with that antibiotic. And what happens is resistance develops over time. Now, we do know from microbiome studies in which we use the DNA of the bacteria to identify it, and we find lots and lots of different subtypes, that Staph aureus is just one of the bacteria that's there. There are lots and lots and lots of other bacteria. In fact, all of us have on our skin what we call commensal organisms, including some types of staph that are not Staph aureus. And what happens in atopic dermatitis is, especially with a flare, we have an increase in Staph aureus. But that's not the only reason we can see infection. We see a reduction in these commensal organisms that just live on our skin and help us out by, among other things, killing Staph aureus. And in those with eczema, there is less of that good bacteria, the commensal bacteria. And unfortunately, even among the commensal bacteria that's there, it doesn't do as well at killing this bad Staph aureus. And we can see other bacterial infections. We sometimes, for example, we see the same kind of strep that gives one a strep throat. But mostly we think about the viral infections, specifically herpes virus, which can give you widespread herpetic infection called eczema herpeticum, or as we've learned over the last several years, a form of hand, foot, and mouth or Coxsackie infection that can look very much like eczema with herpes infection, but turns out not to be that. And that is called eczema coxsackium. Your child may have had molluscum, and molluscum is such a common virus that we see on the skin. It's caused by a mollusca pox. And in those who are predisposed to having dermatitis, when it sets up shop, it can trigger a dermatitis that's exacerbated because of the molluscum. And it's a catch-22 because the dry skin of eczema tends to be a wonderful breeding ground for these molluscum too. So sometimes we see more molluscum in these individuals and can be harder to clear. Now, the next comorbidity is the increased risk of neurologic or psychiatric disorders. And there's some more uncommon ones, but the ones I want to just point out is, one, there is an association with increased risk of autism, but the ones we usually think about are two psychiatric disorders, depression and anxiety, which I don't know that they're related to the eczema per se, but certainly to the tremendous psychosocial effect of this disease on children and on their families. Now, also on this picture of a brain is attention deficit hyperactivity disorder, or ADHD. Sometimes this is just without hyperactivity, and it's called ADD. But regardless, it's been clearly shown that there's an increased risk of ADD and ADHD in those who have atopic dermatitis. And it's something that I think we still do not understand. You might think that in somebody who is scratching all the time and somewhat fidgety and distracted, that a disorder like this might really just be the eczema. But in fact, studies have suggested that some of the characteristics of ADHD are there, but you cannot meet criteria for this disorder with just eczema alone. And that leads us to wonder about the deficit in sleep, and particularly in young children, and how that might affect brain development and learning disabilities, and also may lead one to think about even the fact that you may have the immune shifts that are not just in the skin, but also in the blood, bathing that area of the brain and maybe causing something through a neuroimmune type of access. So just something to keep in mind, that there may be an increased risk of some of these. We need to be on the lookout. And it's one more reason why we really need to treat atopic dermatitis effectively. I want to talk a little bit about social and peer relationships. We worry about this for our children. And yet when children with atopic dermatitis that's active go to school, they can have some pretty profound effects on their interactions with other children, with their teachers, etc. So if you look at the bottom, this was in a study called the Isolate study that was done almost 20 years ago. And what you can see is that particularly in adolescents, shown in maroon, but also in the younger children, 2 to 13 years, shown in the orange, And we can see many children who admitted to being fairly or very concerned about being seen in public. They admitted to having decreased self-confidence, being unhappy or depressed, and bullied or teased because of their atopic dermatitis. Now, there's a concept called stigma. And stigma technically means when there's a false idea that's applied to an individual. And that stigma may be because of external forces, for example, being teased, or it may be something that's internalized, where you just feel that you're not good enough. You have decreased self-confidence and a whole range of other stigmatizing types of thoughts. And I just want to mention this is hot off the press. It's not even been published yet. It's now in press in the major journal of the American Academy of Dermatology. That was from a study of about 200 children who were able to answer themselves about questions that have to do with stigmatization and their mental health. And what this study showed is that 67% of children with atopic dermatitis, if you take all comers, all severities, experience stigma, with greater extents in those with more severe atopic dermatitis. But overall, 50% had at least moderate self-reported stigma, which is quite a bit and is higher than if you look at all kinds of chronic diseases, non-skin, neurologic, cancer, as well as skin diseases. And this stigma itself was very highly correlated with itch. It was very highly correlated with poor quality of life. But in addition, it was moderately correlated with depression and anxiety and psychological stress. So we know that we have to worry about our children and treat them as best we can to move forward their psychosocial development in the healthiest manner possible. Now I'm going to shift over to another group of comorbidities. The word atopic dermatitis, that atopic in it, refers to a group of disorders that are thought to be related to certain types of immune reactions called type 2 immune reactions. And other disorders that are also atopic are things like food allergy, asthma, rhinitis, and others that I'll mention later on. But these are the most common ones. And it's been known for a long time that those who have atopic dermatitis have a marked increased risk of having allergies, asthma, allergic rhinitis, also called hay fever. And if you look at this little diagram that we published years ago when we first talked about this, you can see that atopic dermatitis starts very early on in those first years of life, start a very steep peak, right? Shortly thereafter, or sometimes before, children develop food allergies. And then later in life, we see that increased risk of asthma, we see the increased risk of rhinitis. Now, these are just stylized and they're not reflecting large patient populations. And in fact, it's been shown in large birth cohort studies that there are many, many children who don't have their atopic dermatitis first before they develop other allergies, sometimes even atopic dermatitis after the development of other allergies. But there is a sizable proportion of individuals who start with atopic dermatitis and go on later to get asthma and rhinitis. And then food allergies also, about the same time. Now, I want to emphasize that food allergies are not having a positive prick test or a blood test that shows a specific IgE, high level of something called IgE, that is specific to a certain food. That is not food allergy. That's called food sensitization. The fact that they're making IgE antibodies, these allergic type antibodies, against a particular food. That is not an allergy. To have a true food allergy, either you have to have that and know that you've eaten a food and had a reaction of some kind, it can be a variety of different kinds, anything from hives to gastrointestinal issues, for example, a wide variety. Or you have to, in a doctor's office, be given a challenge of a food and shown to react. So that's a true food allergy. Regardless, here we have a situation where the reason I raise this is because there are all kinds of theories about how the eczema itself and particularly the eczema on the face, where we see it in so many babies, and where we know that the maturation of skin to produce that healthy barrier is the very slowest right here on the cheeks in babies. We think that, at least in many children, that early exposure to foods, not by mouth, where you would develop tolerance, but through the skin and through that poor barrier skin of having affected eczema, markedly increases the risk of developing this type of reactivity. So that we think that in addition to other things, there is a relationship. Now, there is a concept, though. I talked about comorbidities. With these atopic disorders, we like to call them multimorbidities. Why? Because it's a complex relationship where all of these atopic disorders, including atopic dermatitis, can have some at least partially shared mechanism, again, with this type 2 immunity. But not just that. There are shared genetic factors that are known to be linked to each of these allergic disorders. And then there's the shared environment. So you can see things running in families. It's hereditary. Is it because of shared genetic factors? Or is it because of the fact that people who share an environment? So they're in an environment that's conducive to asthma and to atopic dermatitis, for example. So a complex phenomenon. But this is just showing you from 2 large birth cohort studies, one in the yellow and one in the hot pink. And what you can see is in both cases, there is a high prevalence of the co-occurrence of at least 2 allergic disorders, as shown in this study. This is not kids with eczema. This is across the board. If you look at those children with eczema, and not just eczema, but moderate to severe eczema in particular, you can see the high risk of having at least one other atopic disorder. This is from the adolescent study of a drug called dupilumab that's given by injection and has been very, very helpful for so many people with atopic dermatitis that's more severe. And here, if you look across, you can see that 88 to 96% of these patients who were enrolled in this study with atopic dermatitis had at least one other atopic morbidity besides atopic dermatitis. And you can look at these. Now, this is self-reported food allergy. This is not true food allergy. This is according to the parent who gives the history. So only a fraction of these are true food allergy, but a large percentage who at least are expressing the fact that, of course, anybody with atopic dermatitis has often these high IgE antibodies. This is this food sensitivity. But notice asthma, allergic rhinitis, allergic conjunctivitis, and there are a variety of eye problems that can be associated with atopic dermatitis. One is this allergic surface disease called allergic conjunctivitis that is part of the type 2 immune spectrum. And then another is just that there's that rubbing and rubbing and rubbing of the eyes, and that's thought to be part of why there can be some abnormalities that develop in the shape of the eyeball, keratoconus, and even rarely some worse problems like problems with the retina at the back of the eye. Then, of course, we can see increased hives, increased allergies like chronic sinus infections, not infections, inflammation. A disorder called eosinophilic esophagitis, which is not very common, but is part of the same spectrum. And these children often present with food aversion. They don't want to take certain foods, or they may have trouble with swallowing and may have a lot of problems with coughing or other signs, even reflux, some of these issues. And sometimes one only discovers that they have this issue because one does a workup with these kinds of problems, and also the fact that they're not gaining weight well. And something for some of you who may have a situation with your young child, this is something to keep in mind. Nasal polyps, sometimes in adolescence, but usually more of an adult problem. I want to just show this for 1 second, showing you that there have now been several studies of the risk. What are some of the risk factors in my child with atopic dermatitis that would increase the risk of developing some of these other problems and also make the skin disease more persistent? And they are early age of onset, very early age, that is 3 months to 2 years, family history of this atopy, this atopic conditions, and particularly so if both parents are affected by any atopic disorder. The disease severity is greater, that they have been shown to be sensitized. I talked about food allergy, for example, so we can be talking about allergy as shown by high levels of IgE to foods, to dust, to grasses, etc. If you live in a rural environment, you are less likely to get these comorbidities. And if you have the strongest genetic association, which is a genetic change in a gene called filaggrin, if you have that, you have a tendency to have earlier onset, more persistent eczema, and an increased risk of developing these comorbidities with the atopic dermatitis. And this is just showing you again the spectrum of these various disorders in a variety of different body locations, all because of these shared factors. Now, I think this raises two interesting questions. What is the role of IgE, this circulating immunoglobulin E that we know can be increased in patients who have eczema? Now, the interesting thing is that in all of these disorders, it is clear that IgE plays a role in causing the disease. Except in atopic dermatitis, we can see sky-high levels or high levels of IgE, which, by the way, is deemed high based on the age of a patient because IgE levels increase with age. But in atopic dermatitis, we have no idea why it's there. We have no evidence at all that it plays any role in atopic dermatitis, but there it is, and it does play a role in these other forms of atopy. The other thing that I just want to raise here, I'm not talking about treatment today, but I think that all eyes are placed on this IgE now with a question: if we can reverse the atopic dermatitis higher, and rather early in life, and particularly if we can decrease the levels of IgE, will that decrease the risk of developing these various comorbidities during childhood or later in life in those who started early on with atopic dermatitis? And I think it's a really interesting question with some evidence suggesting that reducing that level of IgE may make a difference in the risk or in the severity if they already have these diseases. Just a few more to mention quickly. One is the risk of certain autoimmune disorders. This is an extreme case of alopecia areata, where there is hair loss, as you can see here, very extensive hair loss. Much more commonly, it's patchy, but this is known to be associated with atopic dermatitis. Even patchy hair loss can be associated. I've seen this type of extensive hair loss in people who have mild atopic dermatitis, but regardless, there is an association. We don't really understand why, but treating with medications that take care of the atopic dermatitis can cause the hair to come back. Now, this is a child who was on what's called a JAK inhibitor during a trial early on, long time ago. She's so old, much older now, that her hair is back to its normal color, the dark brown, and it's almost down to her shoulders. I'm sorry, almost down to her waist. But this is when it first came back and came back everywhere, and she was just delighted. It's not just the JAK inhibitors, but even that very specific medication for moderate to severe atopic dermatitis called dupilumab has brought back hair in a lot of children. And there is an NIH, National Institutes of Health sponsored study that just started in which we are putting children who have alopecia areata of at least 30% and either a personal history of any of these forms of atopy, food allergies, allergic rhinitis, whatever, or even a family history of these atopic disorders on a trial of dupilumab to see if it will bring back the hair. And we're having some pretty good early experiences. This is a disorder called vitiligo, in which the pigmentation is lost. It gives you a big white area. This is a very dark-skinned individual, but you can see these cleared areas. And this has to do probably with the inflammation and some changes in the inflammatory state that are going on in the skin. We particularly will see this at areas where there's a lot of scratching. More severe atopic dermatitis, a lot on the hands and feet, and other areas, particularly over joint areas that are associated. Now, the mechanisms for these, again, still unclear, but it probably has to do with shifts in the immune system. Now, a more recently discussed one is poor bone health. So it's been known from some epidemiologic studies that children with more severe atopic dermatitis seem to be shorter and thought to be related to chronic inflammation or sleep. We know that if you don't sleep well, you don't grow well. And then use of steroids. Some kids actually get systemic steroids given to them for their atopic dermatitis, but even those who are on at least moderate chronic use of topical steroids may experience enough that goes into the body that who knows if they're having some effect on their bones. One has also seen increased fractures in those with atopic dermatitis versus children who don't have that. And what's hot off the press is some early evidence that if you treat successfully moderate to severe atopic dermatitis, that bone health biomarkers are improved. And there's some early evidence and now studies really looking at this in that age group, particularly 6 to 11, where they really start their growth spurt, that there's increased linear growth if treated effectively. Now, finally, I'm just going to end by talking a little bit about the need to understand the emotional burden and the effect on the family. This is a study called the Atopic Dermatitis Global Adolescent and Pediatric Online Survey. And you can see large numbers of caregivers, pediatric patients, and physicians who were all asked about the burden in 13 countries. Now, this is just a fancy chart showing you on the left children who are preteens, and then on your right, your adolescents. And I've pointed out the ones where everything's really red, meaning high, 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 top of the list. So your eczema disturbed your sleep, feeling ashamed because of the atopic dermatitis. That was one of the really big ones here. Relief from treatment is limited over time, feeling irritated because of atopic dermatitis and feeling sad or anxious. And then you can see the numbers below that. They didn't come out quite as much, but there was pretty good agreement in these, especially between patients and caregivers. But in some of these cases, if you look all the way to the right of each of these, how the physicians rated them, not necessarily so good, other than that everybody said eczema disturbed sleep and feeling ashamed because of the eczema, which I thought was a very interesting and kind of sad one there. Now, what do parents worry about? This study showed that 68% worry about the long-term consequences of the eczema treatments on their child's health, whether justified or not. 63% worry that the child's atopic dermatitis could worsen in the future. And parents worried about the future life of their kids. And then, as I mentioned before, from just showing you above, the agreement between patients and caregivers was pretty good about how they rank these, but between the patient and the doctors, only 22%. And we see this repeatedly in doing surveys. And the reason I just want to point it out is don't expect your doctor to know. And your doctor who doesn't ask you about certain psychosocial issues or the impact of sleep on sleep, of itch and all of this, you need to tell them. Now, finally, I'm going to just shift to talk about caregivers. We don't talk about caregivers enough, but the burden is huge. So, for example, if you ask about what contributes to the caregiver burden, 80% find the treatment regimen challenging, and they find that it's just difficult to maintain what the doctor said to do in terms of applying topical medications. Here you can see that the burden is related to the disease severity, which of course is also related to what we just talked about. The more severe, the more you have to do. And here you can see that this is the dermatitis family index, and it goes up as we see the severity go up. And not only that, but if you look at the health quality of life in the parents, you'll find high levels, particularly of maternal stress and sleep disturbance in the parents. And in fact, sleep is affected. This is a study that showed for children who are aged 0 to 4 years of age, parents lost 24.5 nights of sleep per year, more than, and then here you can see the, as opposed to the children who were older, 4 to 16 years of age, where maybe there's not as much worry. We still know that parents are taking kids into bed, which is not great. Do not co-sleep. But at any rate, only 6%, I'm sorry, 6 nights of sleep per year were lost, fully lost in parents whose children were above 4 years of age. And maybe that's because just parents are so worried about these younger kids. They have fewer coping mechanisms. Overall, there's lost productivity that accounts for about 50% of the parental burden. And again, depends on severity. This is a study that looked at the mental health of caregivers compared to the mental health of just over all people in general population. And you can see 36% experienced depression, 36% anxiety, versus only 4% for both depression and anxiety, respectively, in the general population. And these are parents of children aged 5 to 16 years. And this is just looking in comparison with parents of children with asthma, which was, asthma is supposed to be a reason too, or you may not be able to sleep that well. And there's some other issues. And of course, worrying about breathing is pretty common. But here you can see that the sleep disturbance was significantly more in AD parents, mothers and fathers, versus asthma parents. Now, I do think a lot of that is the itch and taking these children into bed with you so that everybody can try to get some sleep. It's actually not really helping very much because the kids just scratch. You're up holding hands, trying to keep them from scratching. This is not something we recommend. Get better treatment that does a better job of helping them to sleep. And of course, this kind of sleep disturbance increases the risk of depression, which is twice as frequent in mothers with atopic dermatitis and in mothers with asthma, and then maternal stress being greater in pediatric patients with atopic dermatitis versus other chronic diseases. And this is my final slide about the impact on the family. And we talked about the burden of putting on these topical medications, and we talked about the burden of reduced sleep. But of course, clinic visits, hospitalizations mean missed work and absence from school for children. There is the need to avoid certain foods because of food allergies or suspected allergies. There's special cleaning practices with allergen-free, fragrance-free detergents. And then there's just the financial cost of all of these various treatments and all of the various over-the-counter treatments that are not reimbursed. So with that, I'm going to stop. And thank you for your attention. I'll just summarize by showing this for a minute that once again talks about all of these various issues that create burden. So the itch, the sleep disturbance, the reduction in productivity, especially with diseases exacerbations, the impairment overall in quality of life, and then the comorbidities that include mental health issues and comorbidities ranging from other atopic diseases, infections, autoimmune disorders, and bone metabolic issues that we talked about. And the last comment I will reiterate is that the entire family is affected, especially when a child has moderate to severe atopic dermatitis. And with that, I'm going to just stop and let me stop sharing my screen. And so we'll have some time to take some questions.
Yeah, thank you so much for that excellent presentation, Dr. Paller. We have some great questions for you here. We're going to get to as many as we can, so let's start it off. First question, is severe eczema more common in babies than in young children or adolescents? Where do you see the most severe cases and why?
Well, I see severe cases of everything because everybody sends these tough cases to me. But actually, if you look, there's a greater percentage of more severe disease with older age. So you'll actually see a greater percentage who have more severe disease in adolescence than you do in children and younger children.
Interesting. Okay.
And let me just say that possibly a lot of that is that more severe disease to begin with tends to be more persistent, right? And milder disease is more likely to, for whatever reason, get better.
That makes sense. Okay, so next question. If my child has staph colonization on their skin, will they always have it? Will they always be more prone to infection? How can I reduce the risk of contracting a staph infection?
Well, a lot of that staph colonization has to do with the pore skin barrier. So if we can improve the skin barrier, and particularly not just for moisturizing, but improving it by making sure to reduce the inflammation in skin, which also drives down both the protein and the lipid or fat components of that barrier, then we will see a reduction in Staph aureus. So you can actually see a reduction in Staph aureus on skin from treating with topical steroids. Just reducing the inflammation reduces the Staph aureus colonization. And certainly if we look at studies, for example, dupilumab, that oral medicine, the injectable medicine that has really changed the lives of so many children with more severe disease. If you look at infections, for example, they're markedly reduced. And if you look for colonization, it will be reduced as well. But colonization is even there to a lesser extent in areas that are not even lesional, right? So there are many factors involved in it, but less if in good control.
Okay, next question for you. I wanted to know, is there any studies on children with severe AD from birth to 10 years old transitioning from strong AD symptoms to strong seasonal allergies?
Yeah, there are lots of studies. Well, again, there have been these longitudinal studies, long-term studies starting at birth, identifying the cohort that has eczema, watching to see what they develop. There is a subset who has atopic dermatitis and later gets hay fever, allergic rhinitis, and sometimes it's severe. So again, as I said, you have a higher chance of having at least one of these comorbidities if you have more severe eczema. So they can certainly happen at the same time.
Mm-hmm. It sounds like the broken skin from AD could be the cause for other atopic conditions. Is that so? Are there any comorbidities that might be caused by, not just linked to AD? Are any comorbidities besides bone health linked to eczema treatments? I guess the second one's a little.
Oh, are there? You mean does good eczema treatment improve some of these others?
Maybe we should separate those. So the first.
Okay, so the first question, this is theoretical. That the concept of the atopic march was related to the fact that there's that early exposure. And in fact, there was even a mouse model where you'd induce the eczema first, sensitize to, let's say, egg through the skin, and then look at the development of egg allergy, or it could be asthma or whatever it is, later on in the mouse model. And those who had that skin sensitization with the application to the eczema-like skin in the model had a greater chance of having the asthma, for example, or developing the allergies. So, that really drove a lot of this concept. And I'm sure there is a certain percentage of children, because we know that you don't develop tolerance if exposed through skin, you develop tolerance through oral ingestion. Of course, that goes along with the switch now to try to give kids early food exposure. And ideally early food exposure if they have eczema too, so it doesn't go through the skin, but rather goes through the gut. I think there's a subset at least where that's what's involved. It may not be anything universal. Now, the second question, I think that I did mention bone health got better with good treatment. This has only been shown so far with dupilumab. So will other biologics show that? Will JAK inhibitors show that? Topical steroids I mean, no one's really ever looked at that, but particularly, there's probably particularly a problem with the more severely affected who really need to be using something that's non-steroidal. Steroids will make bone health worse. So I think there's some good evidence of that. But the question was about other ones. And I will say we need better data on concomitant disorders and atopic dermatitis and what happens in the individual being treated for atopic dermatitis. But at least dupilumab, which has been out for a while, and which is why I have more to say on it, is used to treat asthma. There's clear evidence that it reduces IgE levels. We can cut them in half very early. And at least anecdotally, people tell you, yeah, I don't have to use my medications for this or that much longer. Or, oh my gosh, got exposed to the peanuts and didn't go into anaphylaxis. We were able to just give some Benadryl or, whatever, things like that. So there is some evidence, but it just deserves and needs a lot more study, including in comparison among these various new types of treatments that we have available to see what factors are driving this.
More research needed.
More research always needed.
Always. Okay, another question for you. What can be done to restore a better bacterial balance on my child's skin?
Really good question. And it has led to a whole lot of research in trying to get those good bacteria, the commensal bacteria, especially those that kill Staph aureus, onto the skin. Now, there have been a few different directions that go with this. There was one that came out of the NIH. It wasn't a commensal staph. It was actually some other bacterium, and it was looking very promising with some early studies where there wasn't any control to these studies, which is a whole nother topic. But when they finally went to studies in which there was a placebo and the active so they could actually compare, they found it didn't work. On the other hand, we're hoping, for example, that a new medicine that's now being tested that is a form of commensal or good bacteria that kills Staph aureus very well and is now going through some early trials may give a different answer. And so it remains to be seen. So it may be through bacteria, it may be through some other mechanisms to try to fight bacteria. For years we've been using dilute bleach baths or hypochlorous acid that's commercially available to try to reduce Staph aureus without so much changing the rest of the flora. Whether that's also going to be something helpful or not and well tolerated, that's not the direction we're going, but it's easy to get and use.
Great. Okay, I think we have time for 2 more questions here. So here we go. Now that I know all of these comorbidities, how should I work with my child's doctor differently? For example, should I flag all of these comorbidities to my child's primary care doctor?
If these comorbidities exist and you've not discussed it with the doctor, that's a problem. If you're talking about, should I give a list of all of these to my doctor and make sure that at every visit we talk a little bit about them? I think if the child doesn't have any signs or symptoms of having any of these, don't worry about it. Your doctor probably knows about these associations, but maybe not all of them. And I do think that you can keep your eyes open. It's not that many I talked about, but are there any signs of anxiety or depression? Is there a sign where someone is having impulsive behavior, or is hyperactive, or is having some issues with attention that might make you think early on of having attention deficit disorder? Is there a sign of one of these forms of allergy? Is there some hair loss? Your doctor may not even realize the relationship. And the list goes on a bit, but we're really talking about all of these having, not all of these, but some of these having greater risk with greater disease. And also, if your doctor is doing a good physical examination and is taking a good history, hopefully these will come up. But always feel free to raise them if it's something that you've noticed. And I think one of the most important points is that we have great treatments now. There is no reason, very, very few kids who don't respond to one of the treatments out there that's now available. And I have really lowered my bar for using systemic treatments if somebody needs it, because of the fact that it's not just treating the atopic dermatitis, but we may be making a difference long term in what would have been the natural course of that atopic dermatitis if we don't delay too much. And we may be affecting the risk or the severity of some of these other problems that can occur in these kids just by treating effectively the atopic dermatitis. So in addition to the fact that the kids deserve that comfort, there are some other reasons to think about.
Great. We had a question just come in. What is the name of the medicine that you mentioned that works to restore the microbiome?
Oh, it's not on the market or anything. So I'm talking about, so there is something that's got the name SH9, which is a Staphylococcus hominis A9 that is really good at killing staph. Now, if you're talking about dilute bleach baths or hypochlorous acid, those are of course available. It's not clear that those are even working by reducing staph. Hypochlorous acid maybe. So there are some of those around, but that's not an exciting new direction.
Mm-hmm. Okay, well, that's it for our questions. Thank you again, Dr. Powler, for getting us a better understanding of comorbidities in pediatric atopic dermatitis cases. And many thanks to you all for joining us today. You can continue your eczema education on our website at nationaleczema.org. You may register for other webinars or watch a recording of a previous webinar at nationaleczema.org/webinar-Wednesdays. On behalf of the National Eczema Association, thank you all for joining us.